Welcome to the fourth talk in PDF's fifth PD Expert Briefing Series. This one is entitled Managing the Motor Symptoms in PD. For those of you who have not been visited our series before, these webinar series each year, we have 6 of them, cover what we feel to be some of the most important topics in Parkinson's today. And we verify the importance by crowdsourcing, to use the postmodern term, among our participants to see what subjects interest them. So we can then go back and find the very best exponents on those subjects and then introduce them to you as our experts during the series. And we certainly have one today who I'll introduce us in a couple of minutes. I want to say in behalf of the Foundation that we're very grateful, as we always are, to our sponsors for the series, AbbVie Corporation and Teva Neuroscience. These 2 companies are very generous in the support of the series and make it possible. They have no control, of course, over the editorial content, which is the responsibility of PDF. Please note that your PowerPoint slide deck that you're about to see can be downloaded either from the reminder email that you should have received this morning or from the PDF webpage highlighting this talk, which you find through our website. I want to remind those of you who are health professional friends that you can earn 1 free continuing education unit, CEU, through the American Society on Aging. If you did register as a health professional, indicated that you would like to have CEUs, you'll receive an email afterwards with steps on how to collect the CEU. You've 30 days, I'm advised, until April 10th to collect this CEU, so please take action during that period. Please visit our website at www.pdf.org if you'd like to hear more about the Expert Briefing Series or any other educational programs and materials that we deliver, and the researchers and scientists whom we support. So now it's my pleasure to introduce to you our speaker for the day, Dr. Sotirios Parashos. He's an MD, PhD, grew up in Greece, in Thessaloniki, came to this country many years ago and has been trained and educated in medicine, neurology, and in movement disorders in Minnesota, mostly, Minneapolis Clinic of Neurology. He's been a very close colleague and leader at the legendary Struthers Parkinson Center in Minneapolis. Many of you would have heard of it. It's a unique center for Parkinson's, and the country remains, I'm afraid, a unique center to this day. We'd like to see more Struthers centers out there. It's a National Parkinson Foundation Center of Excellence, our colleagues at the National Parkinson Foundation, and it's a terrific place. He's also clinical professor of neurology at the University of Minnesota. His research interest is in those symptoms of Parkinson's that do not respond to levodopa. For example, falls and, of course, cognitive dysfunction, neither of which, unfortunately, do respond to the gold standard drug, levodopa. He's also an expert in the natural progression of Parkinson's disease, how it progresses over time, and also the role of multidisciplinary and interdisciplinary care, which, of course, is typified in the Struthers Center approach in the management of Parkinson's disease. He's authored many, many articles and is a true leader in the field. And we're just delighted to introduce him to as his first appearance in our series and to invite him to speak on this subject that's central to everybody in Parkinson's, which is the motor symptoms and management of motor in Parkinson's disease. So thank you very, very much, Dr. Parashos, for joining us. The floor is yours, or whatever the equivalent of the floor is online. And we'll look forward to watching your slides, hearing your talk, and then afterwards, those people who have communicated with us their questions, I will interpret them to the best of my ability, and Dr. Parashos will have a chance to answer those at the appropriate time. Dr. Parashos.
Thank you very much, Robin, for the nice introduction and the very nice words that you said about me and our center. Good morning and good evening and good afternoon to everybody who is kind enough to attend. I know that there is many people attending from many parts of the world, and hopefully this presentation today will give you some new ideas about how to make your lives better and how to improve your own long-term outlook by better managing the motor symptoms of Parkinson's disease. We will start first with a brief description of all these symptoms, and then we will briefly go over what has to happen in the brain for a movement to occur, and how these processes in the brain are affected in Parkinson's disease. This will give us a better background on the understanding of how medications or surgeries work, and also on how certain types of exercises or other interventions may help improve these symptoms. I will be trying to be as brief as possible in the first part of the presentation, because I want to spend a little more time discussing what a person with Parkinson's disease can do to improve and manage their own motor symptoms. And that would be above and beyond what your neurologist or other allied health care professionals can offer you. So, to begin with, when James Parkinson wrote his essay on the shaking palsy in 1817, he gave this definition for the disease: involuntary tremulous motion with lessened muscular power, in parts not in action and even when supported, with a propensity to bend the trunk forwards and to pass from a walking to a running pace, the senses and intellects being uninjured. And then a few years later, the famous neurologist Charcot in France defined what we know as the classic triad of symptoms in Parkinson's disease, which are tremor, bradykinesia, which is a Greek word for slow movements, and rigidity, which means muscle stiffness. In the 20th century, neurologists also added a fourth main symptom of Parkinson's disease, which is loss of balance. And these four symptoms constitute what we know today as the four cardinal manifestations of Parkinson's disease. Now, these four cardinal manifestations are at the root of all the motor symptoms of Parkinson's disease. Now, for example, the slow and stiff walking of people with Parkinson's disease is the result of bradykinesia and rigidity of the trunk and the leg muscles. Because of bradykinesia and rigidity of the arm muscles, people with Parkinson's disease do not swing their arms when they walk. Because of rigidity of the trunk muscles, they may be stooped and lean forward. The loss of facial expression is due to involvement of the muscles in the face. The same muscles need to work properly to prevent drooling, and when these muscles are affected, speech is affected, becomes more slurred. The voice may become softer because the respiratory muscles do not work properly, and all this may lead to communication difficulties. When the condition affects the dominant hand, the right hand in handed people, the handwriting becomes small and cramped. There's loss of finger dexterity. And when the muscles that move the eyes are involved, people may experience double and blurred vision. When the muscles of swallowing are involved, there is swallowing trouble, there may be choking, things may go down the wrong pipe, there may be aspiration, which is a term that we use to describe when things go down our lungs and they can cause a pneumonia. Weakness can result from involvement of all the muscles in the body, and when the muscles in our pelvis and the legs are involved, we have trouble getting up and sitting down. We may start tripping and falling, and eventually we may develop what's called freezing of gait. All these symptoms, all these motor manifestations, motor symptoms of Parkinson's disease are the result of the four cardinal manifestations. So to understand better how Parkinson's affects movements, we will review briefly now how movements are generated in the brain normally. When it comes to production of movements, there is a chief executive officer in your brain, and this chief executive officer is the frontal lobes. So when I decide that I need to reach out with my right hand to pick up my coffee mug, it is actually the frontal lobes where this decision is made. Now, just like with the CEO of any company, the frontal lobes are not going to bother with the details. So the frontal lobes will communicate the decision to the logistics department of the brain, and the logistics department is the part of the brain that will have to set up everything. The logistics department of the brain is called the basal ganglia. And the basal ganglia is a cluster of nerve cells in the deep part of the hemispheres of the brain and also at the tip of the brain stem. And this cluster of nerve cells has the purpose of regulating movement, of designing and regulating movement. The basal ganglia will collect information from other parts of the brain. So, for example, they will collect information from the vision part of the brain about where that coffee mug is located. They will collect information from the part of the brain that senses the position of my muscles and my tendons and my bones to figure out where my arm is and how far my arm has to move. If I'm moving at that time, if I'm walking or standing or sitting down, different muscles will have to be activated to modify my balance, to keep my balance while I'm doing this movement. So all this information is collected by the basal ganglia, and the basal ganglia then figures out how to make the movement smooth, so it's accurate, it's not too far and not too short. And to do all this, the basal ganglia utilize a chemical that's called dopamine. This chemical is managed by nerve cells that are located in a part of the brain called the substantia nigra at the tip of the brain stem. And this chemical is necessary, and it is central to the smooth movement and handling of all this information from the basal ganglia. Now, once the basal ganglia have collected all that information, and once they have generated a blueprint for the movement, they will immediately communicate this information and this blueprint for the movement to the frontal lobes, back to the chief executive officer, but also will send this information down through the spinal cord into the muscles that will have to participate in this movement to make the movement smooth. Once all this is done, then the frontal lobes literally pull all the stops. So the spinal cord and the muscles are free to perform the movement, and the movement is coordinated and as fast as it needs to be and as accurate as it needs to be to complete the action of picking up the coffee mug. So what then happens is that all this is happening with lightning speed. I am not even aware that my brain does all this. I'm not even aware that my basal ganglia process all this information and they do all the background work. So it's kind of like driving a car with automatic transmission, only quite a bit more complicated. Now, what happens in Parkinson's disease? Remember those little nerve cells in the substantia nigra that use the dopamine to keep the flow of information smooth in the basal ganglia? Well, those little nerve cells die off prematurely in Parkinson's disease. So what happens is that there is not enough dopamine to go around the basal ganglia, and the processing of information in the logistics department slows down to a crawl. The blueprints for the movements are poorly designed and they are inaccurate. The frontal lobes do not release the brakes as easily, and my hand reaches out to the coffee mug very slowly and not as far as it should. If I am in motion at the same time, I may easily misjudge the distance and undershoot or overshoot. The muscle tone between muscles that are supposed to relax and those who are supposed to tighten tends to be all around increased. And the lack of regulation of muscle tone from basal ganglia when I'm resting my arm leads to fluctuations that produce tremors. So how can we go about correcting this problem? Well, the first obvious answer that comes to mind is let's restore that dopamine in the basal ganglia. And we actually can do that, and we do this with L-DOPA. Plain dopamine does not make it into the brain. The blood vessels in the brain are very selective about the traffic of various chemicals to and from the nerve cells. And dopamine is not allowed to get from the bloodstream into the brain. L-DOPA, however, is allowed through, and the basal ganglia cells can use L-DOPA to make more dopamine, and that's how function can be restored to a degree. Other medications we use are dopamine agonists like pramipexole, ropinirole, and rotigotine. These are medications that are dopamine lookalikes, so they kind of like can act chemically in a similar fashion as dopamine in the basal ganglia and restore the smooth flow of information. Another class of medications are monoamine oxidase inhibitors like selegiline and rasagiline. These medications block the breakdown of dopamine and make the dopamine effects last a little longer. And anticholinergics. Anticholinergic medications suppress any opposition to dopamine, and therefore dopamine can do its job even when it is to a degree depleted from the basal ganglia. So with these groups of medications, we can restore function to a great degree. And many persons with Parkinson's may feel very near normal when they start treatment. However, what's missing in the logistics department is not just the dopamine, but also the little substantia nigra nerve cells. They are the actual workers that are responsible for the proper handling of dopamine so that there is not too much and not too little, but just the right amount of dopamine delivered to the just the right place at just the right time so the movement can be smooth. As the disease progresses and more of these cells die off, the function of the basal ganglia becomes erratic, and at times movements are fast, exaggerated, and unnecessary, so we call them dyskinesias, or at other times the movements revert back to the patterns that they had before we started ever the L-DOPA. They become very slow and very stiff and very cramped. That is when doctors may discuss with a person with Parkinson's disease deep brain stimulation surgery. And the purpose of the procedure is to insert a wire into the basal ganglia and with a small electric pulse try to restore to a degree a smoother and more consistent flow of information inside the basal ganglia. And that smoother flow eliminates the wild variations in performance that are at the root of what we call motor fluctuations, that is the dyskinesias and the wearing off. Of course, the holy grail of treating the motor symptoms in Parkinson's disease would be to implant nerve cells inside the basal ganglia. That would be new cells that will take over the job of the dying dopamine cells of the substantia nigra. The efforts so far with fetal cells have shown that this is possible. And there's a lot of interest in developing such surgical techniques utilizing stem cells. I'm sure you've heard a lot about them. There is some indication, though, that the disease can actually spread from cell to cell. And at least for the fetal transplants, we know that the new nerve cells that we implanted there were not immune and eventually were affected by the disease process themselves. So, all this may not be enough. So people with Parkinson's disease ask, what else can be done? And more importantly, what can I do? So we'll talk now about managing the motor symptoms of Parkinson's disease. What can a person with Parkinson's do to improve their own motor function? But also, what can they do to improve their long-term outlook? So we will start with some general principles. Now you may remember that earlier in this talk I mentioned that the process of developing a movement in the brain and developing a movement blueprint or action plan happens almost subconsciously and automatically without us being aware of what's happening. And by us, I mean, of course, our frontal lobes. That's the thinking part of our brain. That is kind of like driving a car with automatic transmission. Well, once you get Parkinson's, your muscles are no longer on automatic transmission. You now have a manual transmission body. Now, the ones amongst you who have driven a stick shift car may remember that when you start learning how to do it, you pretty much have to think through every movement, like when to release the clutch, how much of the clutch to release and how quickly, when to apply the accelerator and how quickly. You may even remember that you almost get in a panic when you have to start on a hill, and you probably, at least I have done it several times when I started driving, you probably have stalled a few times and may even have been rudely honked at by impatient drivers behind you. Now, you're having to think through each movement meant that your frontal lobes, your CEO, your chief executive officer, had to do more of the work. So now that you have Parkinson's, your frontal lobes have to think and remember to make your movements bigger, because Parkinson's makes your muscles move less. So you have to think big when you move, and you have to think loud when you speak. Now, you may remember from an earlier slide that the low voice is in essence also a motor symptom of Parkinson's disease. Many of you may be familiar with the Big and Loud program of physical and speech therapy in Parkinson's disease. And actually, the basic concept behind this type of therapy is to make a conscious effort to shift your movements closer to what would be considered normal. But things sometimes may be easier said than done. You may very well say that you have to think big and loud all the time, and that your frontal lobes have to do more of the work. But this is not very simple. The frontal lobes that have to do the thinking are a very, very busy part of the brain. They are the chief executive officer not only for movement, but for the entire brain and for the entire body. The frontal lobes have to make decisions about all sorts of things all the time. So having to deal with the details of every little movement can be very taxing. It can be distracting and can lead to mental fatigue. And eventually many people will give up. So going back to the example of driving a stick shift car, you may remember that after the first few months, you no longer had to think about every little movement of your left or your right foot or your hand shifting the gears, but all these choreographed movements started happening almost automatically, subconsciously, and actually they were happening even more smoothly than when you had to think about them. So driving a stick shift at this point had actually become a new habit. So this new way of moving, the big and loud way that you need to develop once you have Parkinson's, has to become a new habit. And if you think about what made driving a stick shift a habit, you will realize that this was practice. So, you will get better with practice, and in medicine we have a name for this kind of practice. We call it exercise. So let's talk about exercise a little. Most people with Parkinson's ask, well, what kind of exercise and how much? This is actually a new field of research in Parkinson's disease, and we're getting a lot of information, and maybe we don't have all the answers yet, but we already are having some very interesting answers and very interesting observations. So let's start with the basics to answer these questions. Well, first things first, any exercise is better than no exercise. So a lot of people do not exercise at all. So any little bit helps. Even just doing a few minutes every other day would be enough as a start. Now, there have been a lot of clinical trials in the last 5 years or so, and many different types of exercise have been examined. And actually, I have yet to find a study that did not show a benefit from exercise for the motor symptoms of Parkinson's disease. All these types of exercise have demonstrated benefits in Parkinson's disease: walking, biking, treadmill and Nordic walking, ballroom dancing, yoga, tai chi, progressive strengthening, and stretching exercises are all excellent forms of exercise. What's even more interesting is that their effects are quite global. That is, they affect the motor functions of the entire body as a whole, rather than being specific to the muscles that are being exercised. So, for example, many of you may be familiar with the story of the person with Parkinson's whose tremor improved dramatically after riding a tandem bike for a while. There is very good basic research in experimental animals that has actually shown that exercise induces certain chemical changes in the brain that improve motor function beyond, of course, its effects on just the muscles themselves. Now, of course, it's always sound practice to consult with your doctor first to make sure that you are healthy enough for any particular type of exercise. Or if you actually have some other physical limitations besides Parkinson's disease, to discuss with your doctor which type of exercise may be the most appropriate type of exercise for you. So how much exercise? Well, a good general rule of thumb is that most people should be able to tolerate 30-minute sessions 3 times a week. That's a good starting point. And then you can build up from there as you become more fit. Well, the next point is that some people are physically active. I have many of my patients who come and tell me, well, I do not exercise regularly, doctor, but I'm very physically active. I mow the lawn, or I work the garden, or my job is physically active. These people don't feel that they need to exercise beyond that, and they consider themselves, and they probably are, quite physically fit. They have busy schedules, everything takes them longer because of their Parkinson's, and they cannot squeeze an extra 2 to 4 hours a week to dedicate to exercise. Should they still try to exercise? Well, the answer is always yes. Why? Well, remember what we said about practicing new ways of movement and how this has to become a new habit through regular practice. If you keep being physically active in the same old ways, you learn nothing new. Your body doesn't learn how to do things in a different way. The same goes for persons with Parkinson's disease who may be in the very earliest stages of the disease. They don't feel that they need the extra exercise. If my thumb twitches a little bit and the medicine takes care of it, then why should I dedicate extra time for exercise? They can do pretty much everything normally and without much impairment. Well, I would argue with people that it is easier to retrain your brain and your body to move in a new way when the disease is in the mild, early stages than when it is advanced. So if you decide to exercise for better balance after your balance is affected, you may have missed an opportunity. And although it's always better late than never, it's even better early than late. Okay, so we agree exercise is important, but it's easy to fall off the wagon. Parkinson's slows down everything, and it takes you twice as long to get through your daily chores, and can be discouraging, and can dampen your motivation and curtail your enthusiasm. So how do you keep it up? Well, it has to become a habit. When motivation fails, hopefully habit will pull you through. People with Parkinson's disease seem to like a routine. The organizational abilities of the brain are affected in Parkinson's. So routines and schedules have usually a calming effect and give you a better sense of order. So make a weekly schedule of exercise and then try to stick to it no matter what. Pick something you like. If I tell you that the best exercise for you is biking, but you intensely dislike bikes, or you are apprehensive about riding next to crazy drivers, and you've always wanted to learn how to dance, well, then maybe ballroom dancing might be the better choice for you, because it is more likely that you will stick with it. Have a partner. As I said earlier, sometimes motivation may not be there for many persons with Parkinson's. A loving spouse or close friend can act as an external motivator to get you going. Very often with Parkinson's disease, that's all you need. Someone to get you kind of over the hump, and then you actually can enjoy the exercise and also the companionship. And sometimes you may need professional help. So, who can help when the neurologist says that your motor symptoms are controlled as best as can be done with medications or with surgery? What if they say your motor symptom control is optimized, but this optimal is still not good enough? Well, there is a line of allied health care specialists, a number of different types of therapists who can help improving a lot of things above and beyond what medications and surgeries can help you with. So physical therapists can help with improving muscle strength and balance. Occupational therapists can help with activities of daily living. It can teach you how to do things differently to improve safety and efficiency of your movements. For example, how to put on a coat more efficiently and how to put on your pants while sitting down so you don't fall. They can come up with clever devices to help with eating, dressing, personal hygiene, all sorts of things. The speech therapist can help you with articulation, voice volume and projection, enunciation, communication, also with handling of the saliva, swallowing function, and how to prevent choking and aspiration. Now, as I said, all these people can help you when your neurologist says they've done as much as they can to improve your motor symptoms. But it doesn't have to be that way. You can benefit from physical occupational speech therapy even from the earliest stages of the disease. The therapist can help you with setting up an exercise plan, a long-term goal plan. So by all means, use these services from the very earliest time. So now we will briefly review how we can address specific problems resulting from the motor symptoms. These are a few examples, and of course there are many more, and it would take a very long time to discuss everything, so I will try to focus on these four issues that are quite commonly a big problem with my patients with Parkinson's disease. We'll talk about how to improve activities of daily living, how to try and manage freezing, how to manage and prevent falls, and how to manage speech and voice difficulties. So first, activities of daily living. Activities of daily living are dramatically slowed down in Parkinson's disease, even in the earliest stages of the disease. Just getting ready to get out of the door in the morning may take twice as long. Later in the disease, the fluctuations of the motor function may seriously disrupt the normal flow of your daily routine. So many people with Parkinson's will plan their day according to the time of the day that they feel the most benefit from their medications and when they are the least tired. You may think that this is pretty common sense, but sometimes we look for complicated solutions when a simple change in our daily habits may suffice. A lot of the aggravation arises from having to perform motor actions that are naturally very difficult for a person with Parkinson's disease. So shirt buttons and shoelaces were never designed with a Parkinson's patient in mind. So here are some clever ideas that can make life a whole lot simpler and shave off time from your daily chores so that you have more time to exercise. In the left upper corner here, there are some pens and pencils that are easier to use if you have Parkinson's. Generally, fat pens work much better for a person with Parkinson's. On the top right, you see some funny-looking tools. There is a reacher, and this is a tool that you use to reach things high up in your closet without having to stretch and risk losing your balance and falling. There's also a long shoehorn and a sock device. In the lower left, there is a button hook. You probably don't need to use a button hook for that shirt that I'm showing there. That's a shirt that has fake buttons and Velcro closures. And in the lower right, there are some eating utensils with modified grips. There's a plate guard, so you don't have to worry about pushing your peas off your plate. And a nosy cup that has a cutout for your nose, so it lets you drink without having to tip your head backwards, but continue to keep your chin down, which is actually a great strategy to prevent choking. Now you can see how people with Parkinson's disease have to learn how to do things differently to improve efficiency and save time without compromising safety. An occupational therapist can help you discover other such implements and tools that may make your life easier. Next, we'll talk a little bit about freezing. That's when you feel that your feet are glued to the ground, and it tends to happen in crowded spaces, when going through doors or passages and generate the most inconvenient times. Sometimes may cause tripping, losing your balance, and even falling, especially when you try to pivot. We don't understand very well why freezing happens, and although sometimes it may improve with changing the medications, very often it has nothing to do with how much medicine you have on board at any given time. So here is some simple and useful advice about managing freezing. Freezing tends to happen in crowded spaces more. So if you remove clutter from your living space, there's going to be less crowding, so you're going to have less freezing. But not only this, but when freezing happens, it's going to be less likely that you're going to trip on something and fall and hurt yourself. Now, for some reason, when people with Parkinson's disease have to cross a line on the floor when they walk, they're less likely to freeze. So some people have successfully reduced freezing by adding striped patterns to their floor design, even attaching a strip of bright duct tape across thresholds in places where they're more prone to freeze in their homes. So I have a patient who put a bright yellow stripe of duct tape across the threshold of his bathroom because he always freezes when he tries to get to the bathroom. Now, once freezing happens, it is sometimes difficult to break out of it. So stepping in the same place or rocking side to side are some of the strategies that some people use to break out of freezing. Some people will hum a marching tune, and some people will count. I know a person who uses a metronome. He has downloaded a metronome ticking in their cell phone, and then he can hear that through a Bluetooth earbud when he walks, and that keeps him from freezing. Other people may use a laser light, a laser pointer light, which they point in front of their feet. And I know a person who uses 2 laser lights, one for each foot. Well, not everything works for everyone. Sometimes the best approach is to see a physical therapist who will then probably recommend a gait-assistive device, a walker. Now, this idea may be foreboding for some people, but I have known many Parkinson's patients who have become much more independent, much more active once their freezing was minimized because they started using a walker. Falling. Falling is naturally a big concern once balance is affected. There are many reasons why people with Parkinson's may fall. Sometimes it has to do with tripping. At other times, falls may result from freezing. Parkinson's disease and Parkinson's medications may lower the blood pressure. Low blood pressure may cause near fainting and loss of balance and falling. People with Parkinson's disease are more likely to lose their balance when they try to multitask, when they try to do a complex coordinated movement, like, for example, putting on pants while standing, or reaching for something up high while carrying something with other hand. Other times, falling may happen while trying to get up from a chair or misjudging the distance while trying to sit down. It's therefore important to understand the circumstances of your falls, because this will show the way to prevention, and a doctor or a physical therapist or an occupational therapist can help you figure things out. I have a good example here. One of our patients fell 7 times within 4 weeks. Each single time she fell while putting her dishes away from her dishwasher into the overhead cabinet. I mean, it was very simple for us to advise her to change how she did this, or where she stored her dishes to stop her falling. Now, usually physical therapists and occupational therapists can help you figure things out and help you change the way you do things. Because as we said before, you're driving now a stick shift body, and you have to change how you do things, and you have to think before you act. Now, as I said before, multitasking is not a good idea when you are in a situation where you have to be mindful of your balance. So you may have to start doing many things in the sitting position, like putting on clothes, and even chores like washing dishes, brushing teeth, taking showers, and all that. An occupational therapist can help you falls-proof your home. They can recommend handlebars, grab bars, handrails, changing the arrangement of your living space, advise you on an appropriate gait-assisted device such as a cane, a walking stick, or a walker, or if it comes to that, a wheelchair or a scooter. And the last thing we're going to address today is speech and voice. Now, coordination of the muscles that move your lips, your mouth, your tongue, your voice box, your chest, and your diaphragm is necessary for clear and loud voice and clear articulation. Again, your speaking has to be reset to accommodate the effects of Parkinson's on these muscles. You have to think loud when you speak. In fact, to you, it should feel like you're talking to a person with poor hearing. And this has to become a new habit. You have to make a conscious effort to separate your words and enunciate. Parkinson's makes you run your words together so you can get it all out before you run out of breath. You have to do breathing exercises to improve the respiratory support of your voice. The speech therapist can be a huge help in putting these principles to practice. The speech therapist will give you exercises and homework, and you may think that some of these exercises are kind of silly. But please do the exercises, because remember, this way of talking has to become a new habit. And that concludes my talk. I want to thank you for listening in. And now I think Robin will bring some of your questions to discuss. Thank you,
Dr. Parashos. If we were on a full multifunctional communication system, you'd hear the applause from coast to coast. But you can't because they're not able to, but I'm sure they are quietly. That was a terrific talk and a very, very clear one. And I felt just splendid for those of us who laymen who work with us every day. Nonetheless, there was a lot of good stuff there and very, very good review course. Thank you very much. We've questions of all sorts. I must say a rather unusually good level, if I can say so. My colleagues seem to feel that way too. This first one is particularly interesting to me, from Texas. It's a person who says that it is her understanding that classic PD symptoms are caused by a deficiency of dopamine, but dyskinesias, or rapid bodily movements, by too much dopamine. This person believes that she experiences both. How is that possible?
Well, this is a very common problem in the moderate to advanced stages of Parkinson's disease. If you remember, when I was talking about the logistics department in the brain, the basal ganglia, I mentioned that there are some nerve cells there, the dopamine cells, that have to actually use the dopamine and deliver the dopamine in the right place at the right time. Well, those dopamine cells are dying off as the disease progresses. And so when we give people medication, we kind of like bathe the basal ganglia into dopamine or dopamine-acting medications. So what we end up with is that we have some parts of the basal ganglia have more dopamine than they need, some parts have less dopamine than they need. So it is not uncommon in the more advanced and the moderate to advanced stages of the disease to experience both dyskinesias and Parkinson's symptoms at the same time. We doctors have a name for this. We call it the reversal of the therapeutic window. As the disease progresses, the amount of medication that you need to control the symptoms increases, while the amount of medication that's necessary to produce these dyskinesias decreases. And at some point, those lines cross over, and then you have a reversal where you start having dyskinesias and slowness of movement or tremors at the same time.
That's a wonderfully clear description. What a terrific answer. Thank you very, very much. This next one, as a reward, we're going to give you a simpler one, Dr. Parashos. This is from Albuquerque, New Mexico, a person interested in deep brain stimulation, and she is asking, which of the motor symptoms of Parkinson's does DBS help the most? Maybe we could expand the question slightly and say, what's DBS best at? What is it second best at? What is it third best at?
Okay. Well, first of all, there are different types of deep brain stimulation nowadays. The deep brain stimulation technique was developed also for people who have essential tremor without Parkinson's disease, and so we use a different target, a different part of the brain where we put the wire for those patients. In Parkinson's disease, we can put the wire in a part of the brain called the subthalamic nucleus, or a different part of the brain called the globus pallidus, and the choice depends largely on the treating physician and on the surgeon, but also on some of the symptoms that we try to address. At any rate, the deep brain stimulation is best for people who experience a lot of motor fluctuations. That is dyskinesias, which are the involuntary movements, and wearing off, which is when the medication effect wears off and the symptoms of Parkinson's take over. So people who have this problem are like in a roller coaster. They have times where they feel good, but then they move all over the place at the same time, while they have other times during the day where they cannot move well enough and they cannot do the things that they want to do. And that may be happening despite optimizing the medications that people take. So people who have this kind of a problem are the most likely to benefit from the surgery by decreasing the amount of dyskinesias and decreasing these wild fluctuations, these wild up and downs. Now, the deep brain stimulation surgery itself can be quite effective for tremor, for slowness of movement, and also for rigidity. Generally, we do not expect or we do not necessarily hope for much improvement in freezing unless the freezing happens only when the medication effect wears off, in which case, of course, if we eliminate the wearing off, we eliminate the freezing. But if the freezing happens regardless of whether a person is on or off, then freezing is not going to improve with the surgery, or at least we should not do the surgery for that. Another symptom that will not improve with surgery is falling. And actually, there is some indication that surgery may slightly increase the risk of falling in people with Parkinson's disease. So that is something that you need to discuss with your neurologist prior to making a decision. If falls is a big part of your Parkinson's, then you may want to figure out whether the falls might get worse after the surgery. Now, there are also a lot of non-motor symptoms of Parkinson's disease, like memory loss, confusion, hallucinations. Typically, these kind of symptoms may actually get quite a bit worse after the surgery, and that is why before doing the surgery, most people with Parkinson's disease will have to be cleared by a neuropsychologist who is a specialist, a medical specialist, who will do a very detailed evaluation of the cognitive faculties of the persons. And some people may need to even have clearance from a psychiatrist because depression can also be a side effect of the deep brain stimulation surgery.
Great. Thank you very much. Before I get to the next question, by the way, I'm just advised by my colleagues here that we're running slides, as you undoubtedly will have seen, what I would call public service announcements during the Q&A session. So right now I think there's one up there on resources, materials you can get from PDF. Earlier there was one on the last lecture in our series, and we'll be rotating these. So just keep an eye on the screen for that, but don't let it distract you from Dr. Parashos' wonderful comments. This next question, Dr. Parashos, I thought was particularly interesting. It's a person, again from New Mexico. She has an experience of shaking due to tremors, Parkinson's tremors, but she also feels that some of the shaking in the daily process may be because of drug withdrawal. And I assume she means that maybe she's getting a signal that the levodopa is wearing off, and she is getting shaking for that too. Could you have a comment, perhaps, on the difference between, if there is one, between the shaking that is the natural tremor that comes from Parkinson's and the shaking which some people may experience because of discontinuities in their drug-taking process?
I don't think that we know all the details about how tremor develops in Parkinson's disease. And actually, tremor is kind of an unusual symptom for Parkinson's disease. Some people may have a lot of tremor and not much of the other symptoms of Parkinson's disease, while other people may have never tremor in their life. Some people may have tremor early in the disease process, and as the disease progresses, their tremor goes away. I have seen occasionally patients with whom I start medication, all the other symptoms get better, and the tremor may get worse or not respond to medication. So tremor is kind of like an unusual symptom. Now, what the listener might be referring to is an interesting phenomenon that may happen as the medication effect wears off, where people may experience tremor. Sometimes they may experience dyskinesias that may be very much like tremors just before the medication effect wears off. And we call these dyskinesias diphasic dyskinesias. They're kind of like difficult to treat. What we try to do when we're faced with this problem is we try to either make the transition smoother from the one dose to the next, or use a medication to extend slightly the effect of the medication again so that this drop-off is not as abrupt but smoother, and that seems to eliminate the problem sometimes.
Thank you. Next question is about exercise, and this person from California is asking the simple but tantalizing question, with exercise, is it the intensity of exercise that is most important? Is it the length of time during which you do the exercise, or is it some combination of both?
Well, I wish I had the answers to these questions, but these questions are actually the subject of research that's going on as we speak. I'll give you an example, though. There was a good study that was done in Chicago at the Northwestern University a couple of years ago. What the researchers there did is they decided to compare progressive strengthening, which is actually pumping iron, with just passive stretching exercises for Parkinson's disease. I mean, for the longest time, exercise in Parkinson's disease was stretching. Your muscles are stiff, so you have to stretch them. And people with Parkinson's disease may have a little bit of trouble with weakness, but it's not a big thing. So typically, strengthening exercises was not part of the exercise routine for Parkinson's. But this study showed otherwise. The people who did the progressive strengthening had quite a bit more of an improvement in their motor symptoms than the people who just did the passive stretching. And they retained this benefit for longer. So we don't know the answers to the question the listener put, but what I'm trying to say is that we're trying to keep our eyes open and our mind open because things may not necessarily be the way we think they are. So the best thing would be to make sure that you don't burn the candle on both ends. It's good to work with a personal trainer, and depending on your level of fitness, I would think that the more intense exercises would be important. There's also another thing that I would like to say about type of exercise, and it also speaks to the same question. A lot of the people may be familiar with the story with a tandem bike, and there seems to be at least some indication from research that when you exercise at a rate that's externally imposed on you, you draw more benefit than if you exercise at the rate that your body would naturally go. Make that a little clearer. When you exercise on a tandem bike, if the person in front of you does more of the effort but drives the bike at a higher rate than you're accustomed to, that may be better than if you do all of the effort at your usual rate. So all these are aspects of exercise that we're not clear about right now, but we're finding some surprising findings. And we hope that over the next 5 years, or maybe the next time we give this talk, we may have some better answers.
Great. Thank you. Very, very clear again. This next question has to do with medicinal marijuana. It's from the state of Washington, New Jersey. Washington, of course, they have experience now with, along with Colorado, in wider use of marijuana. And so the question is becoming more pertinent as we continue. And the question is there any research that shows whether medicinal marijuana or derivatives of cannabis, as it's known in Europe, on PD symptoms?
Well, I'm not aware of any large studies looking at marijuana or cannabis for the treatment of Parkinson's disease. The problem with marijuana and cannabis is that for many years it has been a regulated substance, so research could not really proceed, and I'm not aware of anybody doing any large-scale research to see if it works. Now, marijuana has a general calming effect on your body, and when you have high adrenaline levels, that will increase your motor symptoms. So if you get angry, your tremor gets worse. If you get upset, you may freeze more, and so on and so forth. So one could say that or think that possibly by a general calming effect, marijuana might help some of the motor symptoms. But again, this is just a guess and not a scientific opinion.
Thank you. Going back to deep brain stimulation, Dr. Parashos, our caller from Oregon, and also a related question from the state of Kansas, is making the observation that one lives with Parkinson's typically for 20, 25, even 30, 35 years, a long time. At some point, this caller knows levodopa becomes insufficient to manage the motor symptoms. At what point, in general, can you advise that deep brain stimulation would be when is the right time for deep brain stimulation in this cycle? You addressed it generally, but this person wants to get a slightly better, more precise fix on when a doctor like yourself might recommend that this becomes an option.
Okay, well, this is a good question because the current thinking is changing all the time about the correct answer. When we started doing these surgeries, it was kind of like a last resort type of thing, where we would wait until we have exhausted all our options with medications, and then if nothing else worked, then we would go to the brain surgery. Now, there have been some pretty good studies since then. One study looked at people who had the opportunity to have brain surgery but decided against it, and compared to people who went with the surgery. And another study looked at people who could do the surgery but waited another 6 months before they did the surgery versus people who did the surgery right away. And both of these studies have shown that if you do the surgery, first of all, if you do the surgery when you need to or when it's recommended, you will do better long-term than if you don't do it. And once the doctors recommend the surgery, you're probably better off doing it earlier than waiting longer. So since those two studies, I think that people have become, and I'm talking about physicians, have become a little bit more willing to offer the surgery earlier in the course of the disease. Generally speaking, because of the effects of the surgery, you want to do the surgery when the disease is early enough not to have caused significant cognitive difficulties, early enough so that the person is not too old to have brain surgery. At the same time, you do the surgery when you have a good, clear idea of what you're trying to improve. And in most instances, this will be the dyskinesias, the wearing off, possibly the tremors if they don't respond to medications, in a person who does not have many emotional problems, does not have any evidence of significant cognitive dysfunction, and so on and so forth. So it varies from person to person, but my feeling is that on average, if you want to put this in a timeline, on average, when we started doing this surgery, it would be more common to do it 12 to 15 years into the disease. Now we see more often people having the surgery earlier, and now it's not uncommon to see people doing the surgery 8 to 12 years into the disease. Now, considering that this is a technology that's continuously improving, it's kind of like deciding when to buy a new computer, because next year maybe the surgery will be better than what it is this year. So you have to balance out your expectations, how much you want to improve your quality of life right now versus waiting a little longer and possibly, but not necessarily, having a better product.
Thank you. We're over the hour, but Dr. Parashos, before the session, told us very kindly that he would be available to stay on for a few minutes. So I'll take the executive privilege, if I may, and have it continue for 10 minutes longer. Obviously, you're free to leave if you have to, those of you on the phone. But please, hello?
Yes, I'm on.
Good. And so you can stay with us, Dr. Parashos? That'd be great.
Yes, absolutely.
Thank you very much. This was a question it's about exercise again. I should have asked it when we had the earlier question about exercise. And it's from Emersville, Virginia, and the person wants to know, does exercise, in addition to having nice therapeutic effects overall for all sorts of things, in your view, does it actually increase the efficacy of the drug? So in addition to whatever it does to improve one's condition, is it likely that it actually improves the body's ability to take advantage of the medications?
Well, I alluded to some of that in my talk. There have been some very good studies done in experimental animals that have demonstrated that exercising in rats and mice and so on and so forth, exercise produced some chemical changes in the basal ganglia that made dopamine more efficient. So clearly there is more to exercise than just helping your muscles and so on and so forth. I'm sure that it makes medications work better, and there is actually good basic research to support this notion.
Great. Thank you. A couple of very specific questions. California caller would like to know, is there anything in stem cell technology that you're aware of, Dr. Parashos, that maybe have an application in Parkinson's, particularly the motor symptoms?
Well, stem cell technology is a relatively new field, but there is a lot of progress made in other areas besides Parkinson's disease. You may have heard about scientists out east, and I think in Japan, who have been able to actually produce tiny pieces of functioning liver with stem cells. So there's a lot of potential. There's not very much that I should say there's a lot that we don't quite understand yet to fully apply this to Parkinson's disease, but there is rapid progress made, and I think that this will certainly be a very effective way of treating Parkinson's disease in the years to come. Now, the problem with this, we call these surgical techniques neuroaugmentation techniques. These are techniques where we try to either regenerate cells or put cells there that will take over the function of the dopamine nerve cells and so on and so forth. the problem with these techniques is that these cells may in fact also be vulnerable to developing Parkinson's. There has been some indication from the fetal transplant studies that the grafted cells may be affected by Parkinson's themselves. So if that is the case, then and if stem cells turns out to be a good and effective treatment, then it might be something that will buy us extra time, but it may not be the cure that we are all hoping for.
Great, thank you. And from the highest tech potential treatment to the lowest tech potential treatment, what is your view of massage therapy as a therapy for Parkinson's?
Well, you know, just like with any kind of other treatments that I talked in my talk, massage is quite helpful. It can help relieve some of the discomfort that comes from muscle stiffness. It may also help stretch the muscles and relax the muscles. The problem with massage, and again, I'm not talking based on any large clinical studies, but from my experience with my own clients and patients, the problem is that it may not have a sustained benefit. And this is an argument that goes against all the therapies and exercise approaches that we have. You have to keep doing it to keep drawing a benefit from it.
Thank you. And just a general question, just to tie up the whole session, since we've been talking about motor symptoms. Just in general, this is a question from North Carolina. Do people present in your own practice, Dr. Parashos, more with the motor symptoms, more with the non-motor symptoms, or different sets at different times of the cycle of the disease?
Oh, it's a very good question, and it's actually one of the research interests of mine. People early in the disease usually will present with motor symptoms, and that is what there's good research that shows that in the earliest stages of the disease, the motor symptoms are which affects quality of life and daily activities, and that is what leads eventually to the decision to start treating with medications in the early stages of the disease. However, there is very good research that says that if you look 15 years into the disease or 20 years into the disease, the other symptoms predominate, non-motor symptoms predominate, and these are problems with cognition, with executive function, as we call it, like making decisions, judgment issues, sometimes emotional issues, anxiety, depression, low blood pressure, problems with control of bladder and bowel, these kind of problems that are non-motor, and they tend to not respond to L-DOPA or any dopaminergic medications, and some of these symptoms actually may get worse from these medications. Those symptoms tend to predominate when you look 20, 25 years into the disease.
Thank you, Dr. Parashos. I think we'll close there. Rather than make any further comments of my own on your presentation, I asked my colleagues to just pick up some of the reports coming in from the Internet, and we've just chosen 3. From South Carolina, we have standing ovation. From New Hampshire, we have excellent material, exclamation point, exclamation point, exclamation point. And my favorite from California, clap, clap, clap.
Thank you very much.
I think you have it there. But don't go yet, because we'll probably thank you once more. The rest of you who are still on after this wonderful talk, a couple of public service announcements. You have an online survey on your screen right now, I believe, or it's been on. Is it on now? And please, thank you for responding to this. It's something we really do use in our selection of topics, especially for the more arcane topics. Today's was a very common one, important to everybody, but some of the topics we find are for a smaller but intensely passionate, interested audience, and we can only find those out if we get comments from you, so please give them to us. I want to thank our sponsors once more, AbbVie, Inc., and Teva Neuroscience, whose contributions of a financial nature have made this series possible. I want to alert you to 2 other things. There's an archive as most of you know who have been part of the series before, of today's event, which will be made available starting 1 week from now, Tuesday, March 18. Go to www.pdf.org, the Parkinson Disease Foundation website. We'll be sending you an email, because we have all your emails, of course, with a link when it's available so that you can listen to the talk again or let your friends know about it. And finally, the date for our final briefing in the series is Tuesday, April 8, 2014, Tuesday, April 8. It'll be at the same time, 1 p.m. Eastern, daylight time, 10 a.m. Pacific time, and points in between. And the subject will be PD medications, managing the side effects. And this will be presented by another expert, Hubert Fernandez, Dr. Hubert Fernandez from the Cleveland Clinic Lerner School of Medicine. So with that, we'll close our session for today. Thank you, all of you, for coming. I'm advised we had well over 500 actually in attendance, 650 in attendance, and another 600 or so who have signed up and will be actually accessing it through the archive that begins next week. So thank you, all of you, for attending, and thank you, Dr. Parashos, for a princely, clear, and a very important presentation. At that rate, I'm afraid we're going to ask you back. You'll never get out of our clutches. So
that's good. I'm available.
Thank you very much, all of you. Have a great week, and we'll talk to you soon. Bye-bye.